I'm going to move on to talking about pressure ulcers. Can you describe a little bit more clinically just what this is, what happens, who's at risk? How can you do anything about it?
Another name for a pressure ulcer is a bed sore. It's a sore that you get basically from lying in one place for too long.
Yep.
And pressure ulcers can have very serious consequences. So they can be associated with infections. They do dramatically prolong length of stay. They tend to cost a lot.
These are things that develop when people essentially are immobile. They're just not moving very much.
Yeah.
And they can sometimes be superficial, but sometimes they can really become quite problematic.
Exactly.
And can you do anything to prevent these things?
There's lots that can be done, and I think that there'll be much more that it will be possible to do in the not-too-distant future. So there are a variety of technologies that are becoming increasingly available that can track, for example, whether or not somebody is moving.
Got it. And if you're in a place where you don't have a whole lot of technology, for
Yeah.
instance, what can you do that's maybe more manual, less technology-driven?
Sure. So there are good approaches for this. There are also risk approaches for predicting who will get a pressure ulcer, and then it helps a lot to make sure that you turn a patient who you know is not moving very much on a regular basis.
Got it. So one thing that I'm hearing on a couple of these different things is part of the strategy for improvement is not necessarily to just try your prevention effort on everybody, but maybe to try to identify some high-risk people and put extra effort on those. Maybe you can do something for everyone, but extra effort on high-risk patients.
Exactly. That's a big part of the prevention approach.
Okay, great. Surgical complications, what kinds of complications are we talking about?
There's a whole array here, but it ranges from doing things in which you nick an organ while you're doing an operation to cutting something that you did not intend to cut.
Yep. So wrong site surgeries?
Yes, exactly.
And presumably those happen pretty infrequently.
They're very infrequent, fortunately.
Yeah.
But they can be very bad when they do occur.
I can imagine. Let's talk about deep venous thrombosis, other complications. What is this clinically? What happens?
Yeah, so this is developing a blood clot, and they typically occur in the veins, usually in the legs. And the dangerous thing about them is that the clots can then sometimes move up to the lungs and cause pulmonary emboli and trouble breathing and even death.
So you said about 1%, Dave?
Actually, I think it's more like 3%.
Okay, that number should be about 3%. So 3% of patients end up developing a deep venous thrombosis.
Exactly.
And some chunk of those people will end up developing a pulmonary embolism if you don't catch it.
Correct.
And treat it. Okay. Who develops DVTs?
So it's largely people who are at bed rest, and increasingly the people that we bring into the hospital are quite sick, and they do end up spending most of their time in the bed.
Got it. And so the risk is basically from immobility as one of the main risk factors.
Exactly.
And can these things be identified or prevented?
They absolutely can be prevented, and we now have prevention regimens, a variety of different approaches. Those are both medications and then they're mechanical devices.
Got it. So mechanical devices basically that keep the blood flow?
Exactly, that squeeze the leg on a periodic basis. Sometimes people don't like to wear them. They say, oh, it's keeping me up at night.
Yep.
But if they know what getting a blood clot is like,
the trade-off may be worth it.
Exactly.
Yeah. And then medications, presumably you're talking about anticoagulants, things that sort of help prevent clots.
Correct.
Okay. So this is very helpful. This is what it might look like in a typical American hospital. We talked about how these numbers might look very similar if you're in a hospital in England or Australia or Canada.